This program is brought to you by Emory University.
Thanks so much, everyone, for tuning in. Very excited. So my name is Amit Shah, and I'm very excited to welcome you all to Emory Cardiology Grand Rounds this morning. This morning, we have an invited guest, Dr. Rachel Lampert. She is the Berliner Professor of Medicine at Yale University, a practicing electrophysiologist, and an internationally known figure in the niche areas of mental stress and arrhythmias, as well as in sudden cardiac death and sports cardiology as well. Dr. Lampert started actually her education at Harvard, where she studied English, and then was at Vanderbilt for medical school, spent some time training at Bellevue and then Yale, and has been there for many years now. So she spent many years doing a lot of seminal work in the field of mental stress and arrhythmia, doing some, and I'm sure we'll hear more about it today, but things that are really cutting edge, and has been funded by a lot of really interesting studies, not just in the arrhythmia space, but also in the heart failure space, which we will talk more about too. So without further ado, I will welcome Dr. Lampert.
Amit, thank you for that introduction and for inviting me to be here today. I also want to take just a minute to thank Viola Vaccarino for two things. First of all, this is a slide from my first visit to Emory, which was in 2005, which was not only my first visit to Emory, but was my first outside conference anywhere. So it was a big milestone for me. And I would also like to thank Viola for the opportunity to collaborate with her throughout several decades, and not just her, but generations of investigators that she has fostered to move this field of mental stress forward, from Amit to the third generation of Maggie and Anish. And it's really been such a pleasure to collaborate. Also to thank Tanae Lewis, another person here that I've had the opportunity to collaborate with. So to move forward with the talk, I'm going to start with a case that got my interest going in the concept of stress and arrhythmias. This was back when I was a fellow, this case. So this is a 66-year-old man who'd had an MI a few years prior. He had an ejection fraction of 35%. He was at a casino and was noted to have a cardiac arrest. He had bystander CPR, was defibrillated. When he was brought to the hospital, he had not had an ACS. He had a total occlusion of his LAD, and again, his EF was 35%, and he received an ICD. So the fact that this man had a cardiac arrest was not particularly surprising. We know that he had every characteristic associated with sudden death. That's why we have primary prevention ICDs. But why did this happen at the casino? So this is an ad from the same casino that shows everyone laughing and having a great time. But the truth is that what happens at casinos is that people lose money, which is pretty stressful. And so we really thought this was probably the immediate trigger of his cardiac arrest. This is another particularly sad case from a few years later. This was I don't know this person, it was in the New York Times, of a woman who had been a civil servant in New York City for decades. And she was getting ready for work one morning when the police burst into her apartment, tear gas, handcuffed her, and then they realized they were in the wrong apartment. So they left, and later in that day, she had a cardiac arrest and died in an ambulance. Again, a particularly sad anecdote. So in addition to anecdotes like this, what data do we actually have to show whether stress can precipitate sudden death and other cardiac events? And natural disasters or population stressors, such as earthquakes, provide an opportunity to look at this quantitatively. The Northridge earthquake in 1994 was one of the first quantitative studies. So they looked at numbers of sudden death occurring on January 17th, the day of the event. And they compared it with sudden deaths before and after, and sudden deaths on the same date in prior years. And they found an increase in sudden deaths on that date. There were 24 compared with an average of 6. The demographics were similar to that of a sudden cardiac death population. But importantly, only 3 of the 24 occurred with physical exertion, such as clearing debris. And so the rest of these were related to the stress of the earthquake. And this was really one of the first studies to really show this in a quantitative fashion. Another interesting study looked at periods of increased mortality that occurred at Christmas and New Year's. This is from the National Center for Healthcare Statistics. This study controlled for weather, region, and still found that however you looked at this, there were separate peaks on Christmas and New Year's. So what's the cause of this? Well, it's not the weather. There wouldn't be separate peaks. URIs, things like that, all there would not account for separate peaks. Could it be delay of medical care? Maybe. But I think also this very likely is, again, a manifestation of the impact of stress. Similar findings have been shown for many population stressors, other earthquakes, wars, and in one instance, World Cup soccer, England loses to Argentina, increase in Argentina, or in England rather, in acute MI. And in fact, there are not one, not two, but 7 studies showing increases in cardiac events around sporting events. And I put this up for 2 reasons. First of all, because it supports the general concept of stress-induced cardiac events, but also because, my friend Jonathan Kim here is very involved in a lot of these Atlanta teams. And while the Atlanta teams are all very good, they're once in a while they lose, and people just need to keep a little bit of an eye, on Jonathan if that does occur. So when we think about sudden death, there's really 2 causes of sudden cardiac death. One is acute coronary occlusion, and the other is primary arrhythmia. If you do autopsy studies, you can actually see a ruptured plaque about half the time, and half the time you don't see a ruptured plaque. So as an electrophysiologist, I really focused on the arrhythmic aspects of sudden death and how stress may impact arrhythmia specifically. So the first population study that looked at this looked at appropriate ICD therapies following 9/11. And this study came from a center in New York. And they looked at the 30 days prior to 9/11. They used their ICD database to look at shocks, appropriate shocks for ventricular arrhythmias in the days prior to 9/11 and then the couple days after 9/11. And they found that in the 30 days before 9/11, 7 of the 200 ICD patients in their population had had a ventricular arrhythmia. Compared to the 7 days later, it was 8%, and this was statistically significant. A Florida center later replicated this study and with similar findings, just so that it wasn't just in New York, it was really the stress in our whole country of that event. Lindsay Rossman looked at the stress occurring around the 2016 presidential election. She has a database of now remote monitoring. It's now possible using the remote monitoring databases from ICDs to analyze massive numbers of patients and stored arrhythmia data. The 9/11 studies were just done by hand, someone going through all those charts. So what Lindsay showed is that during the period of the election, she again compared it to a control period about a year before. She found that both potentially life-threatening arrhythmias as manifested by ICD shocks and also non-life-threatening arrhythmias such as atrial fibrillation increased in the time around the election. She looked to see whether it had anything to do with, they linked this to voter records, and they didn't actually find, which way you had, whether, your voter registration corresponded. But I think that really everyone was pretty stressed. And so this was another way of looking at this. We looked very specifically in a more controlled fashion at how stress may impact the onset of ventricular arrhythmias. So we did a diary study where we asked all of our ICD patients, and this was an early diary study, just used a paper diary, to carry these paper diaries with them. And whenever they had an ICD shock, to fill out a questionnaire that asked them what they were doing, and then ask them on a Likert scale about their mood in the 15 minutes before they got the ICD shock, and then 15 minutes to 2 hours before they got the ICD shock. And so we asked them, how angry are you on a scale of 1 to 5, how sad, how happy, et cetera. And then we asked them to do the same thing a week later at the same time of day on the same day of the week to serve as a control. And what we found was that overall we had about 100 patients participated, of whom 42 had a shock during the time frame of the study. So we had 107 shocks to analyze in 42 people. And what we found was that the anger level in the 15 minutes preceding shock was significantly greater than control. So you see that in the pre-shock period, there's a lot of people who are reporting having been very angry, whereas in control period, people are not very angry very often. So we then looked at the electrophysiologic characteristics of those shocks that occurred in this study. And we compared the shocks that had been associated with preceding anger to the events that occurred that were not associated with preceding anger. And we looked at several characteristics of ventricular arrhythmias to compare were these the same arrhythmias. And what we found was that those arrhythmias that were associated with preceding anger were more likely to be polymorphic, more likely to be initiated by a PVC, more likely to be pause dependent. And these are all characteristics of more lethal arrhythmias. So here is a monomorphic ventricular tachycardia, which is not preceded by anger, and it's got a sudden onset. Here's a PVC initiated arrhythmia, and here's a pause dependent PVC initiated polymorphic arrhythmia. And I think people is pretty clear. This is a much more lethal arrhythmia than a monomorphic stable arrhythmia like that. So it looks like the anger associated arrhythmias were more potentially lethal. These people had devices, so they didn't die, but had they not had devices, they likely would have. We also looked at the psychological traits of those who did and did not have emotion associated arrhythmias, and found that those who did have emotion triggered events were more likely to have psychological traits of anger, anxiety, and aggressive responses than those who did not. So there are other ways to study mental effects of stress on the body. And the most controlled way to do that is to bring people into a laboratory setting. And that's something that's done here by Amit and Viola and others, as well as by ourselves, to actually bring on stress in a controlled setting and then measure whatever parameter you're interested in to look at the physiologic response. So this is a study that looked at the normal physiologic response to mental stress, or did a stress protocol in normal individuals. So the way you bring on stress in a lab, there's a couple of different ways. What we do is called anger recall, where you ask someone to tell you about an incident in the past couple of weeks that made them angry. And as you know, when you're telling someone about being angry, you kind of get angry all over again. And then we have our psychologist that works with us will then sort of bring it out even more. They're telling you about it, some difficult interaction. You'll say, well, maybe the other person was right. And then they get even more angry. And so it's a way of mimicking those emotions to then look at the response. This used a similar stressor. It was a speech stressor where they were asked to speak specifically about a specific type of incident. So what you see in normal people is that when you bring on mental stress, basically the systolic blood pressure goes up, the diastolic blood pressure goes up, and associated with diastolic blood pressure going up, the afterload goes up. And this is the place where psychological or emotional stress really differs from physical stress. As you know, when you put someone on a treadmill, their systolic goes up, but their diastolic goes down. And that's a very adaptive response because they're vasodilating, they're getting the blood to their periphery, and that's all very adaptive. An increase in afterload, though, never does anyone any good. And this is really not an adaptive response. So you see the heart rate go up, you see, in addition to afterload going up, you see ejection fraction actually going down. And those are all normal responses to psychological stress in a laboratory setting. So we used a similar protocol to look at how stress would impact induced arrhythmias. And we were able to do this because a number of years ago when transvenous devices, ICDs, were first coming in, we did a lot of what we called non-invasive program stimulation. So we would bring these ICD patients into a laboratory setting, and we would bring on their arrhythmias to make sure the ICD was going to work, to see what they had, we're going to program it. Nowadays, that we have many decades of experience with ICDs, we don't need to do that because we know they work and we know how to program them. But so because this was going on at the time, we were able to do a study in which, in people who were coming into the lab anyway to have this non-invasive program stimulation, we did an anger recall protocol on them. These types of studies were normally done with people under sedation, like conscious sedation. But we chose people who had stable pacer-terminated ventricular tachycardias in the past to bring them in because we knew they weren't going to get shocked. We were going to be able to bring on arrhythmias and just look at them without getting the patient shocked awake. So we did a protocol very similar. So what we would do with these patients clinically is we would pace the heart through the device in different patterns that bring on the arrhythmias. So We did this at rest, and then we did it during mental arithmetic, and then we did it during an anger recall protocol. And what we found was that, first of all, the cycle length that we induced of the arrhythmias was a lot faster when we were doing it during mental stress. So this is an example of someone who has this arrhythmia when they are not stressed. So they're awake, but they're just lying there quietly. They have a monomorphic stable ventricular tachycardia that is pacer terminated when they are relaxed. When we're starting to do this stress protocol on them, though, what we brought on instead was a very rapid arrhythmia, which then actually did require a shock. And we found that basically about half the patients had a decrease in cycle length of their arrhythmias, of their ventricular arrhythmias during stress. We also found that the termination was very different. And this, I thought, for me, was one of the most interesting parts. Here's a person having this tachycardia when they're awake, but resting, that is pacer terminated when they're awake, but not stressed. This exact same arrhythmia has got the same cycle length, the same morphology. It's coming from the same place in the heart when they're bring it on when they're stressed. But now when we pace, it accelerated the arrhythmia. And what this tells us is that the excitable gap of the circuit has changed, that the pacing couldn't get in there. The actual electrical properties of that VT circuit were changed by the mental stress and presumably by the catecholamines. So in order to learn more about the mechanisms of this, we looked at T-wave alternans, which is a way of non-invasively looking at heterogeneity of repolarization by looking at beat-to-beat changes in the T-wave. And what we found, this is a new study, we brought a different group of patients with ICDs into the lab, and again performed a similar mental stress study on them. And we found that their T-wave alternans increased during mental stress, as well as some other measures of repolarization heterogeneity. Repolarization heterogeneity is one of the underlying mechanisms of ventricular arrhythmias. And so when we increase that, that may be a mechanism of why, another way of looking at mechanisms of why we're seeing more arrhythmias during stress. We found that those whose catecholamines increased the most during the stress protocol were the most likely to have an increase in their T-wave alternans, implying this was the mechanism. We found that those who had the most anger-induced T-wave alternans were the most likely to have ventricular arrhythmias in follow-up. So here's the ones with the least, this is a number having event-free survival. You can see that those in the top quartile of anger-induced T-wave alternans are the most likely to have an arrhythmia in follow-up. And this really gets to a lot of what Amit is looking at these days, which is how does reactivity impact what happens in the future? And it's really, when you think about cardiac events in general, most of the time you need to have an abnormal substrate. So you have an 80% lesion, or you have a potential VT circuit for electrical abnormalities, but then you also need an immediate trigger. And looking at how those two interact, how the trigger and the substrate interact with one another, may be a more precisely predictive event in the future than looking at the substrate alone, which is what we generally do. So this was a way of looking at the T-wave alternans. So at this point, we had seen that emotional stress was associated with increases in polymorphic ventricular arrhythmias. Others have shown increases in sudden death. We had shown increases in heterogeneity associated with increases in norepinephrine and epinephrine. But as a next step, we next wanted to look at heterogeneity of denervation. And so to do that, we looked at mental stress and while doing MIBG imaging. So when we think about why different types of heart disease are associated with arrhythmia, whether post-MI or cardiomyopathies, one of the things we think about is sympathetic remodeling that occurs during that remodeling, during the structural remodeling process. And the sympathetic remodeling after MI or in heart failure can include areas of hyperinnervation, denervation, alterations in neurotransmitter production, increased neuronal excitability. And basically what happens is that the beta receptors get activated by catecholamines, changes the ionic currents, which alter repolarization. And as I was talking about with T-wave alternans, when we see heterogeneous repolarization is when we see arrhythmias. And so that heterogeneous innervation may be one of the upstream reasons why we see heterogeneous repolarization. So in this study, we did mental stress with patients at rest and then with stress while doing MIBG imaging. And what we found was that all of the parameters that are associated in general with MIBG prediction of arrhythmias increased when we did mental stress. So we looked at the heart to mediastinal ratio. We looked at percent variability in the different regions. And we did this in normal subjects as well. And we found that the normals and the heart disease patients had similar hemodynamic responses to stress, but basically the normal subjects MIBG imaging didn't change, but those who had heart disease did. And this was some data from that study where you can see, this is an ischemic cardiomyopathy patient with things really changing the region in sort of a regional fashion during stress. So I want to switch gears and talk a little bit about chronic stressors and how psychological factors are also associated over the long term are associated with different types of heart disease. So what we've been focusing up till now is really on immediate triggers, but now I want to talk more about over the long term, how these different types of chronic stressors can also impact your health. So one of the first psychological factors to be associated with heart disease was, of course, depression. And so this is an older study from the cardiovascular health study of 4,000 patients who were free of cardiovascular disease at baseline. And depression was measured at baseline. And they found that for every small increment in score, you could see in a linear fashion an increase in CAD risk. So those who were the highest scorers had a 40% increase in coronary disease and a 60% increase in total mortality. So there have been many, many studies showing the correlations between depression and coronary artery disease. And this is just one meta-analysis of 10 studies, but there's many, many studies that show this. So I was part of a study that looked at the influence of depression on ICD shocks. This was called the TOVA study, or Triggers of Ventricular Arrhythmia, that looked at over 600 patients who had some degree of depression. And those who did have depression were significantly more likely to have an ICD shock than those who did not. And so this is another study that looked at depression and outcomes post-MI, showing that the depressed are sooner rehospitalized, more hospitalizations, more emergency visits, more days in the hospital. And this is all well known. So in order to get at some of the mechanisms, Viola had looked at how heart rate variability might differ between the depressed and the non-depressed. And this was really the first study that I was able to work with her on. So she used the Vietnam Area Twins Registry, which is a registry of now middle-aged twins or older who, and in this study, they were discordant for degree of depression. And what we found, and so heart rate variability, to take a step back, is a measure that looks at sympathovagal balance in different ways. And so what it does is it takes the heart rate time series, or the series of beat to beat intervals in your heart rate. And while we think of sinus rhythm as being regular, there are in fact micro adjustments from beat to beat that are based on your sympathetic and vagal activity at the time. And by looking at those changes and quantifying them, we can look at what is your vagal activity, what is the balance between sympathetic and parasympathetic. And what that study found was that basically for all of these different variables in heart rate variability, those who had the most depression had the lowest heart rate variability. And having a lot of heart rate variability is good, because what that means is that you have a lot of vagal control and a lot of ability to adjust your heart rate with changes. When you think to kind of put this in a concrete way, if you think about someone who's very sick in the MICU, that person is 100% sympathetically driven and their heart rate is completely unchanged. When you think about a very healthy person, every time they breathe, they have changes in their vagal activity. So the more healthy you are, the more variability you see. And in this study, we found that as your depression went up, your heart rate variability went down. Skip this one. I spend a minute talking now about social stressors. So I think now we understand social stressors and understand, and social determinants of health. But at one point, this was sort of a radical idea. And this was from about 2002 that people were first starting to think about social stressors and social determinants of health. There actually had been studies on this going back to the 1980s. And one of the first studies showing the impact of social stressors on health was called the Whitehall study, and it was done in Great Britain. And it looked at British civil servants. And basically, Britain is not a place with a lot of social mobility, and people would just get like sort of plugged into their role in life. And so looking at people's jobs was a very clear-cut measure of their socioeconomic status. And what they found was that those basically the higher your job ranking, the lower your mortality. And this was one of the first studies to really show that impact. This has been shown now since that time over and over again. This is a study that looked at that compared both the ARIC study, which is a well-known population study here, with a similar study in Finland. And they looked at education and income, and they looked at total mortality. They looked at cardiovascular mortality, non-fatal MIs. And in each case, both education and income were directly related to outcomes. And these are now well-established associations. So we had looked at, again, looking at mechanisms. Why is that? And there are many reasons why people of lower socioeconomic status have worse outcomes, ranging from differences in care, differences in risk factors. But we postulated that there might be even more just intrinsic reasons why someone of low socioeconomic status might, the stress of that might actually contribute even beyond the risk factors. And so we looked at heart rate variability. This was just a convenient sample of people having Holters at our institution. And we asked them to fill out a questionnaire relating to their education and income. And we found that that as your education and income went up, your heart rate variability went up. And we did control for multiple risk factors, suggesting that perhaps this was related to stress, as opposed, which was then impacting people's sympathovagal balance, as opposed to just risk factors and that type of association. Race has also been very well shown to be a marker associated with poor outcomes. These are, again, some early studies that showed increases in cardiac arrest in Black men and women compared to white. And this is a study now many years or many decades later showing, which is a more detailed study from the Oregon Sudden Unexpected Death Registry, that is again showing that at every age, mortality and sudden death are higher in Black than white individuals. So I thought I had the opportunity to collaborate with Tanae Lewis during her time at Yale. At that time, and I believe since then too, she has really focused on everyday discrimination as a stressor, and how does that stressor impact people physiologically, and how does that then lead to poor outcomes. So everyday discrimination is can be measured on a scale, and it's I think it's what we now kind of at this time people think about as microaggression, but basically people treating you with less courtesy, people ignoring you, receiving poor service, all the different ways that discrimination can occur and can lead to stress in someone's life. So Tanae had first looked at this in the SWAN study in Chicago, and found that coronary artery calcium was higher in African-American women the more discrimination they had faced in their life. When she was at Yale, she did a study that looked in a more granular fashion using interviews of African-American women of their experiences and expectations of racism. The part that I was really working on with her was heart rate variability, and that part actually didn't pan out for this study. But she did find, again, that carotid intimal medial thickness was higher in those who had higher expectations of racism, again, suggesting that just that stress of having those experiences in your life impacted your physiology. So another chronic stressor that is well established to cause disease is PTSD. This was a study that used the VA population and looked at combat-related PTSD and using 2 different scales, and found that the more PTSD these veterans reported, the more non-fatal MI, fatal MI, total mortality they had. And this is, again, now a well-known association. So Viola and Amit and their team have again looked into mechanisms. How is it that this type of stress then leads to physiologic adverse events? And so this was a study that looked at, in that same male twin population, that looked at PTSD and how did heart rate variability vary between those who had and did not report PTSD. And so what that study found, again, those who had the highest PTSD and also the highest combat exposure were the most likely to have dysregulation of their autonomic system. Amit went on to look at sort of the next step in the mechanism. So you have this autonomic dysfunction. How is that then taking us to adverse outcomes? And he looked here at T-wave alternans that I talked about before during mental stress in a population of patients with stable coronary disease. In that study, he did a Holter monitoring during the laboratory mental stress study, similar to what I had shown in our ICD population, and found that those who had reported higher trauma in childhood or early life trauma had greater increases in their T-wave alternans during mental stress. So their chronic stress, their chronic autonomic dysregulation was really enhancing their stress response as well, which was then manifesting in a very specific physiologic response, changing the heterogeneity of repolarization. So I'm going to switch gears again a little bit and talk about atrial fibrillation, another arrhythmia, which is the most common arrhythmia, although not fatal like ventricular arrhythmias and obviously sudden death. So we wanted to understand as well how atrial fibrillation might also be triggered by stress. Anecdotally, I don't know how many of you see AFib patients, but basically your AFib patients will walk into the office with a list of like every episode they've had and what they were doing and what they were thinking and what have you. And so anecdotally, people were always reporting that they're, stressed, and they want to know, is it the stress? Is it, what caused my AFib this time? And so we did a study similar to the diary study that I had shown you with the defibrillator patients in our AF population. But for this one, we increased the rigor of that study. So we did a couple of different things. We gave them what was at the time the sort of going event monitor to record their episodes of AFib. We also had them wear a Holter monitor to provide control periods of sinus rhythm. We then asked them to fill out a diary similar to what I showed you before about what they were doing, their moods. By this time we have moved this diary to a smartphone, which makes it a lot more user-friendly. And we asked them to fill it out at 3 different times. We asked them to fill it out when they had symptoms of AF, during random prompts during the Holter to act as controls, and also every night in addition to act as controls. And what we found was, first of all, that in comparison to the controls, if you looked at the emotions that they had filled out in the diary when they got AFib about their emotions prior to the AFib, we found increases in anger and stress prior to the onset of atrial fibrillation. We also, though, looked at the night before. And one of the reasons that we did this is that any diary study is always going to be biased by a form of recall bias. So if something happens to you, it's a natural human response to try to think about why. And so you're really going to, you're going to be more likely to notice that you are angry or to enhance that anger in your mind. So we wanted to get some prospective data as well to try to counter that recall bias. So what we did, we found with these nightly diaries is that we also found that anger and stress were more likely the night before an event. So this was not a recall bias phenomenon. This was just these people were in a difficult period of their lives at that time. And we could really very much parse out that it was in fact the stress and not a recall bias creating that finding. And so these are just the hazard ratios basically for anger and stress in the proximal or the immediate before, and then again for anger and stress in the nightly, the pre-night night before diaries. This is an example of a single person's scatter plot for his events. And what you can see, so here's all of the diary entries that this person did at night. And what you can see is that, and the red ones are when he has had an episode of atrial fibrillation, and all of these blue ones are not. So when he's not angry, sometimes he has AFib and sometimes he doesn't. But of the 5 times he reported a lot of anger over the course of a year, 4 of them were associated with an episode of AFib the next day. And so this wasn't true. Not every single person had this pattern, but overall, we did see that this was the case in the population as well as in specific individuals like this one. So, at this point, I'm working now, have pivoted a little bit and looking at a heart failure, together with my colleague, Matt Bird, one of the psychologists at Yale. So, heart failure, as we all know, is a huge impact on our society. 1 million hospital admissions per year, $30 billion per year, all, starting off every lecture on AFib, you hear those stats. So this was a study that looked at factors identifying precipitants of hospital admission, because given the burden of heart failure on our society, if we can identify precipitants, perhaps we can help decrease this burden. And so they identified precipitants in about 2/3 of the people, but in 1/3 of the people, they did not identify any precipitant whatsoever. So if you have a precipitant, you can, work on it. You can try to, non-adherence to medications will work on adherence. But in over 1/3 of the people, they couldn't identify anything. It just seemed to be, of the things that they had measured. So could stress be a precipitant for heart failure? Again, anecdotally, people come in your office and they're always telling you about the stress that's going on in their lives when they're presenting with heart failure. So is this something we could actually measure? So this was a study from David Krantz's group, where he measured perceived stress using a questionnaire sort of at different intervals prospectively in a group of heart failure patients. And what he found was that, and then he looked at, when they were admitted for heart failure. And if you compare the readings of their perceived stress on their reading immediately prior to their heart failure hospitalization, it's higher than if you look at the perceived stress readings during the other time periods and in the other people, suggesting that, again, phenomenologically, there may be an association of stress and heart failure exacerbation. One of the difficulties in looking at this is that it's very hard to measure sort of surrogates for heart failure or why this is happening. This was a very old study that looked at diastolic dysfunction. So how are we going to study the effects of stress on heart failure? So this study is an old one that used diastolic dysfunction as a marker for something that might lead to heart failure. And they did a laboratory mental stress similar to what I've been talking about while doing echoes. And they found that some measures of, and this is in patients with heart failure, some measures of diastolic function did change with laboratory mental stress. But that's a sort of it's a very small group of people for whom this might be exactly what's going on. Here, Amit, working with fellow Maggie Wong, has been looking at heart rate variability and how that might predict heart failure. And this was a study that looked at, that Maggie presented at ACC and is now working on the paper, where she and Amit looked at the heart rate variability reactivity, and did that predict subsequent episodes of heart failure. And here you can see that those who have the most decrease in their heart rate variability are the most likely to have an exacerbation of heart failure. So we had started looking mechanistically at this using the CardioMEMS pulmonary artery pressure monitor. One of the things that had really inhibited the study of how stress might impact heart failure was the absence of any surrogate markers. So when we're looking at arrhythmia, we can look at T-wave alternans. If we want to look at ischemia, we can look at a perfusion study. But they're really, prior to the CardioMEMS, we didn't really have much of a window into physiology of what's going on in heart failure. And I think that had really impeded the research as far as looking at stress and how it impacts cardiac physiology. So when CardioMEMS came out, I got sort of kind of talking to my heart failure colleagues, and we said, boy, this is really going to give us an opportunity. That's not why CardioMEMS was invented, but this is really going to give us an opportunity to understand how, why stress and heart failure might be related. So we have an ongoing study now using the CardioMEMS monitor. Most people are probably familiar. This is a very small transducer that is implanted in the pulmonary artery. It's not an active, it has no active components. It's just a transducer, and it's read by an external reader. That tells you the pulmonary artery pressure. And there's studies that have correlated this with the wedge pressure, and other studies which have then correlated monitoring of the PA pressure with outcomes. So it's used clinically. They implant this monitor in people who have hard to control heart failure, and they use it to finally adjust their diuretics and other medical management. So that's the reason why patients get a CardioMEMS, or there's other PA pressure monitors coming out now too, but that's why people get these monitors. But so what we do for this study is we take our CardioMEMS patients and we invite them again to be in a laboratory study. So we're bringing them, this study is just in the middle. So we have two components. So one, we bring them into the lab, and similar to the other studies that we've done with arrhythmia patients, is we measure their PA pressure. You can set this thing up in front of you, and you can see the the beat by beat PA pressure. And so we do, at rest, we measure their PA pressure, we measure their catecholamines and their hemodynamics. We then do this anger recall, and we measure the PA pressure again and all of the other, the ancillary measurements. And then we do the same thing during recovery. So this will give us a very controlled way of looking at what does stress and anger do to your PA pressure. We also have a field component similar to the study I showed you about atrial fibrillation, and the first diary study, where we ask them to do a diary every time they do their CardioMEMS in the morning, and again, which is part of their clinical care. And again, ask them what are you doing, and what do you feel? How angry are you? How sad? How tired? How did you sleep? Etc. To put together there in the real world fashion how stress and other factors may be associated with PA pressure. So this is an ongoing study. So I want to take the last few minutes to talk about what are we going to do about all of this. So, people know I study stress, and they're like, oh, great, maybe that means I, better not go to my in-laws for the holidays. But, I think even if your in-laws are not the bunkers, you have to, stress is a part of all of our lives, and it's not something that we're going to be able to avoid. So how can we manage the impacts that stress has on our physiology? So, first thing I think is pretty simple, beta blockers. So this is a study that looked at changes in ventricular tachycardia with mental stress in pigs. And it was very similar actually to the study that I showed you earlier, where we did non-invasive program stimulation, except what they're doing is instead of doing anger recall with the pigs, they're actually lifting them in a sling to create the stress. This was a model of stress that was used in prior decades. And so what they found was that they could induce the arrhythmias more easily when the pigs were in the sling, and they were faster, which is similar to what we found in the humans. But they found that when they beta blocked the patients in advance, that blocked a lot of their findings. And so we know that beta blockers are important for lots of different reasons, but this may be one of the reasons why beta blockers are so helpful. This is a study that looked at the impact of beta blockers on stress-induced changes in heart rate variability, some of the types of things that Amit is looking at with his team, and found that if you pre-treated people with atenolol and metoprolol, that they actually did have less decreases or less withdrawal of vagal tone or vagal activity during stress. In our study of atrial fibrillation, we found that when we looked at the people on beta blockers and those who are not on beta blockers, basically the findings of association of stress with AFib was almost entirely in the non-beta blocked people. So beta blockers really were providing an enormous protection against stress-induced changes. And that seems sort of obvious. These changes are caused by catecholamines. You block catecholamines, you're going to block a lot of these changes. People have also looked at psychological interventions, and I put up these two slides just to show the number of psychological interventions that people have attempted as far as teaching people how to manage their stress to avoid some of these, avoid these effects. So this is one, this is just a small one to show you about psychological intervention after ICD implantation that randomized patients to a cognitive behavioral therapy versus usual care, and then looked at the CBT involved teaching them how to deal with anxiety, disordered cognition, how to stress management, and all the things that CBT includes. And what they found was that certainly it improved their depression, anxiety, and psychosocial distress when they did get a shock. If they had the CBT. This group then looked at whether the psychological intervention actually improved the receiving of a shock, and found that that basically not only was anxiety less with the psychological intervention, but they actually at 3 months, they had a big difference in whether the patients had received shocks. And at 12 months, they did too, although it was a small study. And so it was not significant at 12 months. But this study did suggest that teaching patients how to manage their stress would be beneficial as far as preventing future shocks. This was a study that looked at yoga and found similar findings, that basically the patients who were randomized to yoga had less psychological distress, such as anxiety and depression. They felt better about having their device, but they also found sort of in a small group trend, it might reduce shock episodes as well. This was a study that looked at yoga in patients with atrial fibrillation, and found that it did significantly decrease the number of symptomatic atrial fibrillation episodes, but it also sort of got them feeling better in general. So it's a little bit hard to say how much of this was sort of their perception of what was going on versus actually decreasing the changes in rhythm. I looked with a medical student at one time who was very interested in integrative therapies at a therapy called Reiki. Reiki is sort of a combination of like massage and meditation, where someone like lays their hands on the patient and sort of like focuses on them, and it's used clinically in hospitals, and it has a lot of benefits as far as psychological distress. So it's actually used in our hospital as well, and there's a lot of studies about that. So what this young woman did in our study was to look at how Reiki might impact heart rate variability in patients who are in the CCU recovering from an ACS. And we randomized patients to either a passive control where they were just resting, to music that was supposed to be quiet, relaxing music, and then to this Reiki intervention. And what we found was that, first of all, Reiki was much better at decreasing the psychological distress in the patients after MI, with them being less angry, stressed, frustrated, et cetera, compared to both the control and the music. But also we found that their heart rates went down the most with Reiki, and that their heart rate variability had the most increase, so that it increased their vagal tone better than the music or than the rest. So this was just a short-term study, but did show the benefit, the physiologic benefit of a complementary intervention. So in summary, anger and negative emotion can trigger ventricular and atrial arrhythmias and potentially heart failure. Chronic stressors also increase cardiovascular disease. And so what approaches may be the most beneficial at decreasing emotion-related arrhythmogenesis and better understanding of mechanistic pathways are all important avenues of future research and ongoing research at our institution, at your institution, and elsewhere. So I'll stop here and take any questions.
Thank you so much, Dr. Lampert. That was tremendous. Very comprehensive. We have some questions here. I have the mic. And okay, Chris is going to pass it back. I'm also looking at the chat.
Thank you so much, Rachel. That was a fantastic talk, as I always hear you give.
Thank you.
So thank you for coming down here as well. So I have a question to kind of meld in your expertise here with obviously where you and I work together quite a bit as it relates to the care of young athletes. And you're obviously well aware of the differences in risk of sudden cardiac death between young competitive Black athletes versus white athletes, and also very aware, at least that's been shown in a few epidemiological studies, also aware that the most common cause of sudden death in athletes are the autopsy negative cases, really shown in numerous epidemiological or registry type data sets at this point as well. So one of a recent data that is unpublished. Tene is well aware of this. She's seen this, but we've looked at young athletes, and it's really interesting. They do tend to significantly report a lot of young Black athletes much more experience with everyday discrimination, which is very interesting. I think, when you're looking at a healthy 18-year-old athletic population, to see those differences, maybe not surprising. But my question is trying to think about potentially mental stress, underlying mechanisms for sudden death. Stress cardiomyopathy is obviously very hard from a postmortem standpoint to see by autopsy. And so it's just something I've been thinking about a lot. I'm curious your own thoughts about trying to tie all this together potentially as could there be a relationship there, in terms of what we see both from an autopsy standpoint, but just epidemiologically as well.
Well, so that's a great question. So I think, first of all, just as stress cardiomyopathy, I would separate out from sort of the more diffuse impacts of stress on the electrical system, on coronary. I didn't talk about like stuff like coronary vasoconstriction that you also see with stress. So there's a million mechanisms of how stress leads to bad outcomes in addition to sort of formal Takotsubo, where you actually see the ballooning and what have you. There's many ways that stress can contribute. I think some of the data that I showed before talks about the effects of chronic stress and how socioeconomic status, the everyday discrimination that Tene has studied, impact chronic stress and how that may set up the substrate. So sort of thinking again about like, how does stress impact the substrate? How does stress impact the trigger? So in thinking about the substrate, I think that's a lot of the work that, the stuff I showed of Tene is about how the stress of everyday discrimination directly impacts your physiology. And, I'm just sort of postulating here, but I think that it's not surprising that a Black athlete might be even more prone to that than other Black individuals of that age, because they're like in the public eye. So, most people are just, going about living their lives and they interact with the small group of people that they interact with, but athletes are interacting with like huge arenas full of people, much more than others. And so I think that probably, I can imagine that would be exacerbated. And so I think that certainly some of those chronic effects may be part that change the substrate, could certainly potentially impact some of that that we have seen in that difference epidemiologically in sudden death in the Black athletes. Whether it impacts the trigger is a little harder to know, and would be, I think, pretty hard to study because of the rarity of the rarity of sudden death in athletes at all. We can't just give them all, diaries and have them filling them out, have like tens of thousands of people filling them out all the time. But I do think studying some of the chronic types of manifestations of stress, whether it's the types of things like IMT or heart rate variability that are surrogates for physiology, like how stress is impacting physiology, would be really interesting to evaluate.
Okay. There's a lot of interest in wellness in the workplace in the United States, and with various companies, and also in healthcare now. And healthcare workers are noted to be under marked increased stress. How do you envision potentially using some of these technologies that measure heart ability and those types of things, at looking at different causes of stress in the workplace or interventions?
Well, so I think a lot of parts to the question, but so I think as far as thinking, you could certainly use them to just look at stress in the workplace. So people have actually done that. I had those as some of my backup slides. People have looked at how job stress, impacts health. And you see the same types of findings as you see for all the other stressors I talked about. People that are under high levels of job strain have worse clinical outcomes. And so certainly looking at HRV and those other types of surrogate markers in that population might explain that mechanistically. In thinking about interventions, I think interventions to decrease stress in any population are important. And like with my patients, I don't think there's one specific intervention. Should it be therapy? Should it be, yoga? Should it be whatever? I think it's whatever works for you. And so when I have patients, I don't talk about stress with every patient in my office because we don't have time. But when patients do seem to be talking about stress, as they're with sometimes patients we all see are sort of more focused on that. How are you doing since I last saw you? And then boom, they launch into their stressors.
Yeah, I think I may have worded that wrong. Maybe interventions of what employers can do. So for instance, I think if you were to have measured heart rate variability in our healthcare system back in early November of last year, when we had a very poor rollout of Epic, you would have seen tremendous stress.
Yeah.
But there are things that impact everybody across the system, and how can you get leaders and administrations to look at the various impacts of various things that they might do.
So to think about the impact of stress, I think if you could just ask them is one thing. Just give them a questionnaire to talk about how they're doing as far as their stress levels. If you wanted to quantify that, you could certainly use heart rate variability. But I think where I was going with the individual person that you talk about how to manage their stress, I think that institutions should also be thinking about, well, first of all, when you're talking about a rollout an epic rollout, which we've all experienced, and can certainly personally testify to the stress of that. I think they should be focusing on what they're doing wrong and getting it right. But I think in a more general sense, certainly thinking about ways that employers can help their employees reduce their stress in general is helpful. So some institutions offer things like stress management. Ours, one of the best ways to manage stress is exercise. And I think both exercise is good for you just because it's good for you, but it's also very effective at decreasing psychological stress. And that's certainly something that our institution doesn't force us to do, but there's many, there's like the walking apps that you sort of pretend that you're walking with your colleagues, even though you're walking on your own, but you're all doing it on the app, whatever. I mean, we have a lot of that type of thing and different ways to incorporate exercise. But I think doing that, we have small programs for stress management, but certainly I think they could be larger. If one wanted to look for if one wanted to quantify, so if you're the person that is, going to roll out this intervention and you wanted to quantify it, then I think heart rate variability would be a pretty simple way to do that, because you can do it. It's non-invasive. It's pretty easy. The wearables, many of the wearables do incorporate HRV. How well they work right now, I think that actually causes more harm than good, probably, because it makes people so anxious and crazy. You have people calling you, like people I know, friends call me like, oh, my heart rate variability is down. I need to see a cardiologist. I'm like, well, probably not. But I do think that certainly those things can be better harnessed for the type of question you're asking about.
Thank you so much. I think we have 3 minutes and 3 questions at least.
And I'm curious, beta blockers, it makes a lot of sense, and you show effects on surrogate outcomes. Apart from heart failure, it's not so much considered a drug like the best antihypertensive, or even for MI, it lost some indications, and evidence are questionable. So what's your take on beta blockers for prevention on this thing? And I had another second question regarding the substract. Atherosclerosis, you showed Dr. Williams' paper. How much do you think we know that stress leads to atherosclerotic burden?
Well, I think that's something that Viola's team has looked at as well, right? And shown changes in, perfusion imaging. And that's sort of the part of things that I focused on the most as an electrophysiologist. But, people in my own institution have also looked at silent ischemia and perfusion imaging with stress. And so I think that there's actually a fair amount of evidence. I assume that's where you were going with all of this, that there is a fair amount of evidence of increasing atherosclerosis due to stress. I think the beta blocker aspect, my take-home message there was not so much that every person should be on beta blockers, but to say that by blocking catecholamines, you change this effect. And so beta blockers are the most, hammer way to block catecholamines. But all of these types of interventions, yoga, whatever, one of the ways they work is by increasing your vagal tone, which then counters, provides some counter against catecholamines. And so I think that I don't think that beta blockers also have side effects. And I don't think that my take-home message isn't here that like every single person should be on one, but that it does demonstrate sort of how we can start to think about blocking these effects.
Hi. So, thank you, Rachel. That was wonderful.
Give to me.
I have a question about, as you know, we study women versus men here, and the extent to which one of the mental stressors is, so some of what I'm finding in my own data is that it's the stressors that happen to other people that women are most vulnerable to. And I think one of the mental stressors is about a stressor happening to someone else, right? Like your loved one in a nursing home,
Yeah.
et cetera. So in the anger recall, do you see differences for women versus men, and not just in responsivity to the anger recall, but also in the types of things that get them revved up? Is it harder to get the women revved up? Are they more revved up about these kinds of events that involve loved ones versus some random person? So just curious what your thoughts are on that.
You know, those are good questions that we haven't really looked at. I've worked with many of you in ways, whereas for me, what I'm often looking at is just like the end organ. Like, can we change the end organ or not? As more than sort of like which of the stress, like how the different stressors themselves impact different people. We did try to look at men versus women in the ICD studies, but we didn't, just like in any ICD populations, we didn't have enough women to really look at it. Maybe I'll put the question back to Amit and Viola. Have your HRV reactivity studies shown differences in men and women?
So we have found early on that there was a sex difference. I think as we've collected more data, we've seen less of that. I think that we what's pending probably is more detailed analysis to get at maybe some of the interactions, and but I think that it's worth exploring further. So Umber had a question. Can you excellent talk. Can you please talk about resilience in relation to acute and chronic stress, and if physiological responses make it blunted with better resilience?
Well, that is also a really excellent question that I think, would be very well addressed by, many of the sort of the psychologists in the room and elsewhere, using the same type, and you can use the same types of physiologic surrogates like HRV reactivity to study that type of question. So I think it's really a question that really brings out the value of this kind of interdisciplinary approach, where you're thinking about you're using some of these physiologic measures as a way of really thinking about these psychological questions. But I mean, I would imagine, yes. And actually, I think that Becca Levy, some people in the room know Becca Levy, who is a psychologist at Yale. Some of her studies sort of indirectly impact that, which she's looked at how elderly people think of themselves. And it's not exactly resilience, but it's sort of similar in that the elderly people who have these like negative self stereotypes, like they think that they have bad sort of images of elderly people, do worse than the people who see, growing old as a positive. And I think that's sort of similar. It's not specific measures of resilience, but I think the ones who have the more sort of positive coping mechanisms do better.
Any other questions? I do want to recognize the time. Thanks everyone who could join virtually and in person. Dr. Lampert, of course.
Thank you. It was a pleasure being here.
The preceding program is copyrighted by Emory University.